This is Edward Grant, and I'm the chairman of radiology at the University of Southern California Medical School, and today I'm going to be talking about upper extremity venous disease. Good morning. Today I'm going to be talking about the upper extremity venous ultrasound examination, and in particular I'm going to emphasize its use in the evaluation of both acute and chronic venous disease. When I think in terms of venous disease in general, I think it's worth pointing out that there are definite differences between several of the problems that we encounter with upper extremity venous disease that are not the same as those that are encountered with probably the better known venous disease of the legs. The vast majority of upper extremity venous disease has its origin from catheters, and for this reason probably explains why there seems to be such an increasing prevalence of upper extremity venous thrombosis and associated complications, given the fact that in most hospitals the majority of patients will have some form of either central or peripheral lines. Obviously, as you can see from these statistics, the indwelling central catheters carry a far greater risk of upper extremity thrombosis than do peripheral IV lines. Also, other areas that may be problematic for or associated with upper extremity venous disease are cancer and hypercoagulable states, which for the most part are often the same entity, in that patients with cancer are often hypercoagulable and may develop thromboses in unusual places. Probably the most important other group of patients with upper extremity venous disease are the so-called patients with effort thrombosis. These are basically patients who have a form of thoracic outlet obstruction or hypertrophy of the anterior scalene muscle, such that there is compression of the proximal outflow of the subclavian vein and the predilection for diffuse thrombosis distal to that. Luckily, this is relatively rare. I think another important set of clinical features of upper extremity venous disease are complications. And it's interesting that catheter-induced deep venous thrombosis tends to have a better prognosis than those patients in whom there is primary or effort thrombosis. Those patients, again, who develop acute thrombosis secondary to outflow obstruction proximally from an anterior scalene enlargement or possibly hypertrophy. It's also important to remember at this point, although the prognosis of the primary or effort thrombosis may be poorer probably because there's such massive thrombosis and destruction of the valves, that at this point most of these patients are acutely treated with thrombolysis, which may in fact improve the outcome of this group of patients. Also important to point out that upper extremity venous thrombosis may be associated or a cause for pulmonary embolism, and the literature would tell us that probably around 10% of patients with pulmonary embolism will actually have the clot originating in the upper extremity veins. It's somewhat comforting to think, however, that these rarely cause death, and that basically this has been reported as between 0 and 2% in several series. This is probably secondary to the fact that the clot burden, the size of the clots that arise in the upper extremity veins, are much smaller than those that arise in the legs, and therefore are much less prone to actually kill the patient through blockage of the pulmonary vasculature. It is important to remember that approximately 1/3 of patients with upper extremity venous disease will develop post-thrombotic syndrome, which, similar to what is seen in the legs, is probably secondary to a destruction or fibrosis of the jugular venous valves, and again, resultant stasis. Also important to point out that jugular vein thrombosis, while it may be a rather spectacular thing to look at sonographically, it does not go or does not cause pulmonary emboli, and is really of very little clinical import. Does not lead to post-thrombotic syndrome either, and for that reason is probably why so many of our patients with indwelling catheters, at least acutely indwelling catheters, now have them positioned in the internal jugular vein rather than the subclavian vein, which of course does set up the possibility for thrombosis and resultant post-thrombotic syndrome. The technique that we use for scanning the upper extremity veins may involve any one of a number of differing transducers, so it's a good idea to have multiple of them available. Most typically for general scanning, we use a linear array with as high a frequency as will permit good penetration to the vessels, depending of course on the size of the patient. In occasional patients with very large shoulders or very muscular or obese patients, a curved array may be helpful in scanning the axillary area as you traverse that region. And for the identification of lesions or problems in the area of the internal jugular or subclavian junction, any transducer with a very tiny footprint, which some people call baby head transducers, with a small footprint that gives you a wide field of view, may actually help you to insunnate this area, which is typically surrounded by bone, and may even allow you to get some imaging of the innominate veins. Typically, I begin the examination by placing the transducer in a medial fashion, in the medial upper arm, transversely, identify the arterial and venous landmarks, and then proceed proximally in a longitudinal orientation until I'm blocked by the clavicle. Once you get to that region, I then jump up over the clavicle, look for the internal jugular vein, and follow it as proximally as I can. Again, if there's a question of orientation, turn the transducer into the orthogonal plane, and that will also show you the surrounding, usually the adjacent artery or other veins, and help you with your identification of landmarks. Now, the upper extremity normal venous anatomy is nicely shown in this particular diagram. I think the thing that is probably most unique about it is that, remember, unlike the arterial tree, there is a brachiocephalic or innominate vein bilaterally. So there is a left and right innominate or brachiocephalic vein. This is formed by the junction of the jugular veins and the proximal subclavian vein, following the subclavian vein out laterally to its junction with the cephalic vein, which is the large vein that comes along the lateral side of the arm. After this point, it ducts through the pectoral muscles to become the axillary vein, and eventually then emerges in the upper arm and divides into the basilic, which is a superficial vein, and the deep brachial veins. The brachial veins are usually multiple and closely applied to the brachial artery. Again, a diagram I think shows this very nicely. The superficial location of the basilic vein, which is really not paired with an artery, and the fact that there are usually multiple small brachial veins, which are smaller than the superficial veins and closely associated with the brachial artery. Remember the division of the axillary artery into the brachial, and then the brachial into the radial and ulnar arteries and veins is extremely variable and actually may occur anywhere through the length of the upper arm. This is a patient in whom you can see that there has already been division of the brachial artery into the ulnar and radial artery in the mid portion of the upper arm. We do use compression where it's possible. Obviously, compression is not going to be easy or possible once you get up underneath of the clavicle, but in the more peripheral portions of the upper extremity venous system, we use compression wherever it is possible. Again, in some of the larger patients with a lot of musculature or extremely obese, may be a good idea to actually use a curved array, lower frequency probe to be able to identify usually the axillary arteries, the only one that you'd actually need anything like this for. And of course, as I mentioned, looking for the junction of the internal jugular vein with the subclavian vein, these very small footprint transducers with a fan-shaped array or visualization of the vessels can actually be beneficial and get us way down into the chest, which would otherwise be impossible using a linear probe. Always very important in the upper extremity venous system to identify the normal venous pulsations. Remember, this is a typical systemic vein which is closely connected to the right atrium and therefore should have this very choppy kind of sawtooth triphasic pattern that is typical of most central systemic veins. We also may identify catheters in these veins. The cephalic vein or any of the veins in the upper arm may actually be used for venous access, particularly PICC lines and other long indwelling catheters. Now, going back to the old literature on some of the original articles that were written on using upper extremity Doppler, you can see the results were fairly good. I think that probably a more realistic article was one by Knudsen et al., which showed a 78% sensitivity and a 92% specificity for upper extremity venous thrombosis. But do remember, this was a mixed population and that they did not use the multiple transducers that we have available today. So this was done with a linear probe, and I think that our results should be better than they are in this early study. Also one by Joe Pollack, which showed 100% sensitivity and specificity. Now, Joe's really good, but the reality of it is these were all effort thrombosis patients. They had massive thrombosis, so you really should have 100% sensitivity and specificity in a population like this. Now, the diagnostic criteria for acute upper extremity venous thrombosis are very similar to what you would expect to find in the legs. First, you look for the presence of hyper or hyperechoic thrombus. It's very variable, just as we see in the legs. Absent color and spectral Doppler should be obvious. You obviously also may see color around a thrombus. They may not be completely occlusive, and that really doesn't have a whole lot of clinical relevance. As I mentioned, we look for lack of compression from usually the axillary vein on out. And for chronic venous thrombosis, we also tend to look for, or central thrombosis that's not visible on the ultrasound, look for loss of that normal triphasic spectral signal. Some people have likened it to a portal vein signature. Also remember, collaterals develop very quickly in the upper extremity veins and can actually cause confusion. These are a couple of classic examples or typical examples of what you see in the brachial distribution. You can see the vein on either side of the brachial artery, and again, these are the brachial arteries. This transverse image of the same patient shows you that the two brachial arteries veins applied very closely to the artery, and the basilic vein, which is actually, again, larger and more superficial and not paired to an artery. Therefore, it is a superficial vessel, even though in this particular case it may harbor more clot and be larger than the accompanying brachial arteries. The axillary vein can actually get quite large when it's distended by thrombus, as is the case here. Just as in the legs, I think we often see anechoic or hypoechoic thrombus, but as is the case here, this is a large thrombus which is expanding the vessel. It's bigger than the adjacent artery. This is an acute axillary vein thrombosis. We have largely come away from performing venography unless intervention is being contemplated, but certainly venography was something that was quite commonly performed in the old days. At this point, I think between ultrasound and MRV, we've largely replaced it. Again, as I mentioned earlier, you may actually find these vessels are expanded and are traversed by a catheter, which is probably the root of the thrombosis itself. If you see collaterals or vessels beyond an obvious thrombosis, again, you will probably lose that nice triphasic waveform. Here you can see we have a collateral dumping into the subclavian vein and an absolutely flat portal vein kind of flow without the expected pulsatility. Good idea, just as in the legs, to always document the proximal and distal extent of the thrombosis, particularly the proximal extent centrally. If these patients show up again for a repeat examination, it's a good idea to know or be able to at least document, has this thrombus propagated? And you can only really do that if you know what the proximal extent of the thrombosis was on an earlier scan. As I mentioned, it's very important to compare the two sides and look for that triphasic signal. Here you can see on the right that nice normal triphasic signal that we showed earlier, comparing that in the same patient to the signal, the spectral signal from the opposite subclavian vein, absolutely flat. This is good evidence that there is a central thrombosis or at least occlusion. If you can't see it, obviously we don't know which it is, but certainly this is very good evidence that there is some form of central blockage, whether an acute thrombus or in most cases probably a chronic thrombus. But always very, very important to document, at least in the subclavian veins, a couple of images of the triphasicity of the normal vessel. If we do a unilateral study, as part of our protocol, I always insist that we also obtain some images from the opposite side because, again, the normal phasicity of the upper extremity veins is very, very variable from one person to the next, and it helps to actually have that image from the opposite side so that you can use that as a baseline for comparison with the other side. This, of course, may fall flat if you've got bilateral brachiocephalic or superior vena cava disease, but for the most part, I think it's a very important thing in the upper extremities to have that comparison of the spectral patterns. You can have partial thrombosis in these cases. In such cases, you will usually find an area of elevated velocity, and it's interesting that in this area, usually the phasicity will return once you get into the actual area of narrowing, as is the case here, and you can see that there is partially occlusive anechoic thrombus to the one side of the vessel. You can see an area of color aliasing within that narrowed region, and it's confirmed that there is high velocity flow in this selected region by the spectral tracing itself. Now, do remember that there may be extrinsic reasons for narrowing and resultant thrombosis of the upper extremity veins. This was an elderly man who was sent to us from a nursing home with swelling of the arm, and you can see that there was thrombus identified in the vein itself, which extended distally, but that the vein was actually quite narrowed by a solid mass. In this particular case, we went back and reviewed the chest x-rays on this gentleman, and needless to say, there is a mass in the apex of the right lung. You can see there's already a metastatic deposit in the rib on the left, and this turned out to be a squamous cell carcinoma of the lung, an apical tumor, a Pancoast tumor, and that we actually biopsied this under ultrasound guidance. So do remember, everything that affects the veins may not be intrinsic to them, and to look around. This is obviously also the basis, for example, of the effort thrombosis in those patients in whom there is enlargement of the anterior scalene muscle with entrapment of the vein leading to outflow obstruction and resultant massive thrombosis. Now, as part of our routine examination of the upper extremity veins, we do not tend to include the cephalic vein. This is a large vein that, as I mentioned, extends along the lateral edge of the lateral side of the upper arm and then anastomoses with the branches of the basilic and brachial veins in the antecubital fossa. This is really a clinical diagnosis. The thrombosis of the cephalic vein is really, for the most part, a clinical diagnosis. If there's a thrombus there, you can probably see it. And better yet, you can even feel it as a ropey area of thrombosis on the lateral side of the arm. This is that vessel that you see in well-muscled people along the biceps muscle laterally. So we don't tend to include that in our normal examination. As I mentioned, we do tend to include the basilic vein since it's right in that area where the rest of the vessels live, the brachial veins live, the brachial artery. And this is a relatively large vein which can carry a considerable clot burden. Again, whether it's the cephalic vein or the basilic vein, these are often used for venous access lines, and in this particular case you can see that we have a thrombosis around an indwelling catheter. Now, I mentioned that about 33% of patients with acute venous thrombosis will develop chronic venous disease, post-thrombotic syndrome. And this is another area where ultrasound may be used to clinical advantage. First of all, it's important to know in these patients whether you're dealing with residual clot or acute clot versus what often happens in these patients, both in the upper and lower extremity veins. After a thrombotic episode, the vessel may simply fibrose down. So it's important to know whether you're dealing with fibrosis or whether you're dealing with clot from the standpoint of both imaging and possible resultant thrombolytic treatment. Now, as far as the sonographic features of upper extremity venous thrombosis, or chronic disease rather, we look for a residual or recanalized thrombus within the vein, just as occurs in the lower extremity. The thrombus will begin to shrink and fibrose down as time goes on. So a small thrombus, again, probably smaller than the adjacent artery, should tip us off to the probability of chronic venous disease or chronic venous thrombosis. You may actually see true recanalization of the thrombus. Look for collaterals. Remember, there's a very rich collateral bed around the upper extremity and shoulder, and so collaterals will begin to open up very, very quickly around any deep venous thrombosis. Just as we had mentioned earlier, we look for a decrease in the normal spectral phasicity, again, as some people call it, this portal signature, where you actually have a lack of phasicity due to the presence of, or the absence really, of direct contact between the flow in the upper extremity veins and the normal pulsatility of the right atrium. Also, you may actually see consistent visible narrowing, either on grayscale or color, and oftentimes in these cases you will actually see a focal region of increased spectral velocity. Remember that while these narrowed regions may be secondary to thrombus, and often probably are, they are not uncommon in patients who have long-term indwelling catheters, whether it's actually cases of silent thrombosis leading to fibrosis or actually irritation from the indwelling catheter itself is not known, but certainly it is well known that you may actually have true stenoses of these vessels. Now, many patients are able to open up collaterals around them and decrease the resultant arm swelling, but it is sometimes necessary to go on and stent these patients. So this is an important thing to identify. Remember not to create it by pressing too hard with your transducer. If you press too hard with the transducer, you will actually cause narrowing and potentially increased spectral velocity. So make sure that you're very light in your touch and don't actually cause transducer-induced pseudo-narrowing. Also do remember that, again, differentiating collaterals from the native or the real deep vessels may be quite challenging. Always look for consistent anatomy. Look for the adjacent artery so that you know that you're dealing with the adjacent large vein rather than a large collateral that is formed. As I mentioned, there is the potential for the opening of a very rich collateral bed all throughout the upper arm and shoulder area. Even in the jugular area, it's remarkable how patients can open up huge collateral beds across the neck when there is blockage on one side. Again, always look for that nice normal spectral waveform, a choppy triphasic waveform. Here you can see that this vessel looks perfectly normal by grayscale evaluation, but there is a definite lack of that normal triphasic pulsatility. In this particular case, following the vein centrally, you can see that there's an area of intense aliasing, which is very nicely defined as a very, very narrowed channel in this proximal subclavian vein. This is an interesting piece of physiology which tells us a lot. If you look at the color pattern on this particular patient, you can see that the subclavian vein is displayed in blue in that it's going away from the transducer, but the jugular vein is displayed in red going up toward the patient's neck. So in this particular case, with or without abnormal spectral lack of phasicity, by the physiology here, you can clearly see that the innominate vein on the left is out, probably chronically thrombosed or scarred, and that flow comes down through the subclavian vein and then reverses its course going up into the jugular vein. And as I mentioned, it's remarkable how rich a bed of collaterals can open up when the patient needs to get around a central obstruction on one side or the other. So the color pattern in this particular case is essentially diagnostic of a central occlusion. Here you can see on the venogram that there is complete blockage of the flow centrally, and that flow is now shunting up through the jugular system and across to the other side to get around this central innominate vein occlusion. As I mentioned, it is extremely important to compare the Doppler waveforms from one side to the other. An older study actually claimed that ultrasound was not particularly good for this, and it has been stated that about a quarter of patients who have catheters in their veins will develop a DVT or stenosis, and these may be silent, as I mentioned. And what these are, the reason they're discovered is simply through the inability to catheterize veins when one tries to insert such things as a PICC line. So people have actually done pre-PICC line scanning. We don't do an awful lot of that anymore. And a study done a number of years ago showed that ultrasound was really only 27% sensitive for identifying these so-called central occlusions. I think that this probably does not give justice to the results that we can achieve with ultrasound at implying or identifying these central occlusions. And another article published a number of years later actually showed very good results. And this article actually looked specifically at the waveform rather than actually identifying a stenosis, which I think most of us would say is going to be very difficult visually. In this particular article, they actually compared the waveforms from one side to another with an eye toward diagnosing or implying central occlusions, as we've discussed earlier. They took 21 patients in whom there was absolutely no abnormality seen by grayscale or color Doppler imaging, and they looked at asymmetry in cardiac pulsatility and respiratory phasicity. And they found that asymmetry in cardiac pulsatility was 100% sensitive and specific, and that respiratory phasicity, or a decrease, a unilateral decrease in respiratory phasicity, yielded a lower sensitivity but was still perfect with regards to specificity. So again, very, very important when thinking in terms of these almost silent occlusions that we compare with the waveform from the opposite side. Now, in closing, an unusual entity that may be encountered is something known as a venous pseudoaneurysm. This is a rare complication of trauma. I think most commonly these are actually going to be iatrogenic, and again from puncture of the veins. Usually the internal jugular vein is the most common location. And this will be seen sonographically as a saccular outpouching of the vein, which contains pulsatile flow. And you can see that the pulsatile flow will actually essentially be in sync with the motion in the adjacent vein. You can actually see a squirt of flow going into this sac on either grayscale or color or power Doppler. Again, it is most commonly going to be found in the internal jugular, probably because, again, at this point, the internal jugular is probably the most commonly punctured upper extremity proximal vein. The important thing about venous pseudoaneurysms, as opposed to those which affect the arteries, is not to get excited about them. These are not clinically significant. There's no reason to intervene and remove them or not to thrombose them as we do with various arterial pseudoaneurysms. Again, these can be quite dramatic sonographically. Here you can see the jugular vein in this particular patient. My mind mind was originally completely reversed on this. I actually thought it was the carotid artery next to the jugular, and then I realized, oh, it was actually lateral. So you can see a small neck here, and you can see pulsatile flow extending out of the jugular vein on this power Doppler image. Likewise, I think the grayscale also shows this kind of swirling flow which rhythmically moves, and some of it settles out within this internal jugular pseudoaneurysm. So again, an unusual entity, rather dramatic images, but the important thing to keep in mind is that these are clinically of no significance and really do not require any kind of intervention. So with that, I think we will close our session.